A pleasant evening to all, our dear doctors and participants. We're now formally welcoming you to the Atopic Dermatitis Summit 10.0 with a theme, A Decade in Review. This AD Summit is a project held annually by the Pediatric Dermatology Subspecialty Core Group of the Philippine Dermatological Society in partnership with Galderma. It is indeed a fruitful evening for each one of us as we are joined by industry experts to conduct meaningful sessions on atopic dermatitis. And now, to formally open the program, please give your virtual warm round of applause to the Philippine Dermatological Society President, Dr. Francisco D. Rivera IV.
The PDS Atopic Dermatitis Summit is a gathering of board-certified dermatologists, opinion leaders, and participants with special interest in this kind of eczema. I would like to congratulate the Pediatric Dermatology Subspecialty Group headed by Dr. Mariel Nicolas for organizing this year's AD Summit. I also would like to take this opportunity to congratulate the PDS Pediatric Dermatology Subspecialty Group, who is now a subspecialty society of the PDS and duly registered at the Securities and Exchange Commission as the Pediatric Dermatology Society of the Philippines. PDS will always be with you in your journey in promoting excellence in providing the best dermatological care through training and education, developing standards of care so we can provide quality services to our patients, creation of relevant researches, linkages, and advocacies. I would like to honor Dr. Mariel Nicolas, the head of this group, and all the leaders in the past and members of your group, because you pursue your passion to achieve who you are today. The PDS Atopic Dermatitis Summit will always be your means in promoting the best dermatological care in this disease. And my prayer is for our Lord to prosper you. To all our participants, let us consider this achievement of PDS and its subspecialty a great blessing that comes from our Lord through this group, the Pediatric Dermatology Society of the Philippines. Mabuhay ang PDS, mabuhay ang Pediatric Dermatology Society of the Philippines, mabuhay tayong lahat.
Again, let's give our warm virtual applause to Dr. Rivera for his inspiring opening remarks. To those who just logged in, welcome to the 10th AD Summit, A Decade in Review. Feel free to settle down as we're about to start our learning sessions in a few minutes. And now, to give her own welcoming remarks, let's call on the screen the President of the Pediatric Dermatology Society of the Philippines, Dr. Marie Eleanor O. Nicolas.
Good evening, everyone. It is my honor to welcome you all again this afternoon to our 10th year of our Atopic Dermatitis Summit, entitled AD Summit 10, A Decade in Review. As you all know, this is an event that we began as the Pediatric Dermatology Subspecialty Group of the Philippine Dermatological Society. And now we continue as the Pediatric Dermatology Society of the Philippines. This 2022 will be different. We have two good news for all of you. 2022, we will have a two-day event, tonight and tomorrow night. And also, today we get to launch the Pediatric Dermatology Society of the Philippines. Join us as we celebrate our humble beginnings with a short video launch. Before then, thank you to the Philippine Dermatological Society who consistently support the programs of the Pediatric Dermatology Society of the Philippines. I would also like to thank our sponsors, Galderma Philippines for day 1 and Johnson & Johnson Philippines for day 2. So for tonight, we will have two interesting topics. On first, evasive measures for atopic dermatitis by Dr. Marvi Dizan, and unfolding infections and atopic dermatitis to be given by Dr. Donna Sarosa. For day 2, tomorrow, we will have the evolving landscape of topical treatment to be given by myself and systemic therapy and atopic dermatitis through the years to be given by Dr. Cindy Tan. Please don't forget to register on the link for tomorrow's event as well. So let's go on with the PDSP launch for today's program.
Thank you, Dr. Nicolas, for those meaningful words. And now's the time we've all been waiting for. We encourage everyone to put all their eyes and attention to their screens as we witness PDSP's video launch.
So, Marivi, they're asking us how and when pediatric dermatology started here in the Philippines.
You know, Donna, come to think of it, when we were training, there was really no clear-cut separation of general dermatology and pediatric dermatology. When we finished our training in our respective institutions, we already were encouraged by our mentors to seek further training. And so, on our own accord, we were looking for any subspecialty that we can hone further our skills, depending on what we were interested in. So I was going around in the US, and it just so happens that there was an opening for pediatric dermatology under Dr. Amy Power at the Children's Memorial Hospital of Northwestern University in Chicago. And so after I finished that wonderful training, that is when I came back and started practicing the subspecialty. And it was then that I got to collaborate with Dr. Roberta Romero, who eventually I realized she has been doing pediatric dermatology for so many years already here in the Philippines. So at that time, she opened the doors for us to be lecturing in institutions and also to do international lectures. And later on, you came. A year after I came back, you came back from your training.
Yeah, incidentally, I had no idea that you were also practicing or took some training in pediatric derm because I was in Canada. I also was looking for a subspecialty, and there was an opening for pediatric dermatology at Hospital for Sick Children with Dr. Bernice Kravchik. And when I got home, I realized that, PDS was also very accommodating, putting us in plenary sessions already. And there was always, when we had our conventions, they would give us a slot for pediatric dermatology. So it was a growing specialty, right?
That's right. So, Donna, how has pediatric dermatology grown in the past 10 years?
Well, if you look at it, Marivi, this year marks a very important year because 2022 is our 10th year doing the Atopic Dermatitis Summit. But actually, it has really grown vastly because we started with just three of us maybe, and then later on we were 6, right? And then now we're more than 15 of us. And so we're really a growing society. And that's why we have decided to form this Pediatric Dermatology Society of the Philippines.
I will never forget that first year we did this. It was like we were just a small group, I believe, 6 of us, and we did our level best to do the first year right. And there was a typhoon, but even if there was a typhoon, we were able to carry out that project well. And ever since, with the family growing, we've been having wonderful projects, very fulfilling projects along the way. And it is why we are where we are at right now. So, Ivy, how do you envision pediatric dermatology to be in the next 10 more years, 10 additional years? Hmm. For sure, we'll still be there. Yes. Okay. Can't get rid of us. Why? Because we love the subspecialty so much. And we have already carved our niche, not only in the local scene, but we are contributing tremendously in conferences elsewhere, abroad, like in the International Society of Pediatric Dermatology, World Congress of Pediatric Dermatology, the regionals. So we are there. And in the next 10 years, I believe I can see others having interest in taking pediatric dermatology as a subspecialty to take as training. And in the future, we will definitely be there to train more colleagues who are interested in this field. After all, it's a beautiful subspecialty and it's very dynamic. So we're here to stay. We will be there with them, and you will be with us through the next 10 years.
Our original logo was actually conceived during the time when we wanted pediatric dermatology in the Philippines to have a face and be recognized as a field of expertise dealing with both common and not so common pediatric dermatological conditions, no, in this age group. So it was an original blue and gold color with the child and parent in the center of a circle. Now, years later, we revised our logo to reflect the dynamism and youthful vibe, especially since our small family has suddenly expanded to include younger, excellent, and equally dedicated and warm-hearted members who finished their fellowships from different parts of the globe. We wanted our logo to embody the mission vision that our society represents. So our society name is colored green, reflecting kindness. Yellow reflects enthusiasm. Light blue reflects wisdom. Red reflects passion. And orange reflects optimism. So all of these colors are intertwined into a heart with a common dream of providing quality dermatological healthcare for our Filipino pediatric patients.
Good evening, everyone. Thank you for joining us for the launch of the Pediatric Dermatology Society of the Philippines. The idea came up a long time ago, and it was a dream that we continually hoped for. Except that we didn't have the numbers then. However, through the years, what we would do is we would encourage dermatologists in training to take further training in pediatric dermatology. And every time one would finish, I would personally message them and ask them when they will be back. And I would already give them the procedures on how they can join us. And I really see it every time I introduce a new member to the group. The new member is always enthusiastically welcomed. So through the years, our numbers have grown, and we are very happy with that. And early 2021, it was such a blessing to our group because the building of the subspecialties became a priority project of the Philippine Dermatological Society. It was so perfect timing for us because we were already completing our numbers. So the Philippine Dermatological Society with its officers, Dr. Jojo, Dr. Noemi, Dr. June, Dr. Charm, and our cluster head, Dr. Blossom, and of course, the PDS board, they were all very supportive of our endeavor to be a society. So it was very timely for us. And by August 2021, we finally had the numbers with the return of a fully trained pediatric dermatologist. So it was time for us to now build our constitution and bylaws. So we started meeting October of 2021 and September of 2021, and we finished our constitution and bylaws. But considering that we were saving on funds, we didn't want to register by November 2021, also because of the advice of the Philippine Dermatological Society. So I did defer it to January of 2022. So by January 13 of 2022, I had requested for a meeting with the PDS and the accountant of the PDS. And before this meeting, I had researched on all the procedures that need to be done to become a society, which I specifically asked the accountant with all the forms that needed to be filled up. Starting with the registration with the SEC, then registration with the BIR, and eventually registration for employee safeguards. So that's what we went through. Early part of 2022, and now everything is history. We are now proudly the Pediatric Dermatology Society of the Philippines. So our objectives include: first, to provide appropriate, comprehensive, and individualized dermatological care for pediatric patients; to foster an interest in pediatric dermatology; to advance the practice of pediatric dermatology by holding summits, scientific meetings, seminars, and eventually a fellowship program; to provide and disseminate educational materials in pediatric dermatology; to conduct research and encourage publications relevant to pediatric dermatology; to uphold professional and ethical standards among pediatric dermatologists; to protect members of the society against unfair practices; to promote local and international recognition of our pediatric dermatology society; to establish linkages with dermatologists and other subspecialties for more comprehensive healthcare; and of course, to foster camaraderie among members and colleagues from other countries. It is our vision that the Pediatric Dermatology Society of the Philippines be recognized as a leader in the field.
Describe pediatric dermatology in one word: dynamic.
Mind-boggling. Amazing.
Challenging.
Empowering.
Commitment.
Awesome.
Pediatric dermatology is heart.
And fulfillment.
Love. Love, love, love. I love it.
What a time to be really inspired! Seeing the official video of our beloved PDSP really motivates us to keep on making a difference in our lives. Moving on to our official learning session tonight, Atopic dermatitis is one of the most prevalent skin conditions in the country, affecting people of all ages. And to further discuss this topic with us, especially on evasive measures for atopic dermatitis and what we can do about it, introducing to you. She is an associate professor at the College of Medicine and Dermatology, University of Santo Tomas, Manila. She's also the head section of pediatric dermatology at the University of Santo Tomas Hospital, a founding member and board of directors member of the Asian Society of Pediatric Dermatology, a past head, Pediatric Dermatology Subspecialty Core Group of the Philippine Dermatological Society. Let's all give a warm virtual welcome to Dr. Maria Victoria C. Dizon.
And this now will cause an impaired barrier function which of course is the skin. And this is the most replicated genetic risk factor in atopic eczema development. Now, here comes the external aspect, which is the environmental factors, the pollution, the allergens that's coming from outside, and even the scratching that goes on. The mechanical damage has absolute negative impact on the filaggrin expression. And of course, these two combined will create this skin barrier dysfunction. And we know that there are the physical connections that are depleted, that are disrupted because of what, again, will create this skin barrier disability. And finally, of late, what is of great interest is the impact of the microbiome, which is on the skin. And when there is a dysbiosis that occurs, this is because of the domination of that pathogen, which is the Staphylococcus aureus, that also adding up to all these bring about further barrier impairment. So we do remember the inside outside and the outside inside hypothesis, which brings about the problem of atopic eczema. But now we see that there is a great concentration of interest, a greater concentration of interest on the external aspect or the outside aspect of that outside inside issue. Now, we've seen this stepwise manner of managing atopic eczema, and we are all experts in how to manage this, but I will just get to the the highlighted points of this step up management. It's still part of it. This has never changed since decades ago that skincare is essential. It has never changed as well the importance of using emollients or moisturizers on the skin. But of course, it is vital as well taking showers or baths, and depends which territory of the world you are at. There's some that they advocate almost on every other day bathing. But of course, in our hot, humid country, we have to tailor make it according to our environment. So that means everyday bathing is vital and more helpful if it is twice a day made that you take a bath. Now, trigger avoidance. Yes, it is totally different as well from what our North American references have highlighted. Here, the trigger, of course, is the sweat. So we have to profile our patients according to the locals, what those triggers are, and try to work around the problem so that it will create a lesser flare or even prevent the flare. Now, as you see that there is already some add-ons from the previous step-up management of atopic eczema. Here, we see already the targeted therapies incorporated in managing these patients. You have the crisaborole, and then you also already have the inclusion of the biologicals. And even when, no matter what the spectrum of the disease is, still, we use the good old topical anti-inflammatories, depending upon the potency that you will reach out for and depending on the clinical spectrum that you are faced with. But now, when it comes to the severe aspect, even the nuclear warheads already now they are absolutely efficacious in handling atopic eczema. We're talking of the biologicals again, whether they are injectables or they are oral drugs. But we still have use for the good old guys, the systemic immunosuppressants. And now, seeing this in the management of atopic eczema, the question is, are we able to use this statement that's in front of us? Yes, there has been an absolute explosion of new therapies. This is the exciting part. This is the biological era. And so the new AD treatment is very promising. But you know what? Even if you use those kinds of drugs, there are still challenges and obstacles that would cause a flare of the condition. But also, did you ever wonder, is it ever possible to evade the disease? And when you say evade, you think of preventive measures. I want to prevent the problem. I want the condition to, as much as possible, not manifest itself. Prevention of the disease is more cost effective in managing chronic diseases. That's a general statement. And one of the examples of the chronic diseases is atopic eczema. And yes, this is what we have to think about. But can we do something, at least from the get-go, something that would be evasive, something that would be preventive? And we take a cue from you. It's like the evasive measures need prevention strategies to be able to dodge that filaggrin mutation, and hopefully we're not going to become atopic. So this is now where we see what are the different types of prevention that we could think of. And when you think of prevention, that means there's a form of an intervention. So the intervention, I'd like to liken it like a traffic light. Of course, this is something that Filipinos always want, always green. But I just put this thing upside down. Why? Because when it comes to the prevention, primary prevention is that stage wherein we still manage the patients even before a health problem is seen on the patient. So in this case, if we are dealing with the possible of an eczema coming into the picture, we can make use of moisturizers as a possible preventive strategy. But of course, no matter what happens, somewhere along the highway, there is something that may go wrong, and there's already a mild problem that will see itself in the landscape. And that means now we are somewhere here. The secondary prevention now entails introduction of something stronger and something of a longer early treatment in the hope that we will be able to stop this at its tracks or try to keep it as it is. But again, unfortunately, no matter what happens, everything goes wayward, and sometimes we fall off the grid. And this is where, when we see already patients in that stage of severe lifelong eczema, we are now thinking of, this has to stop. This has to be put in under tertiary prevention. And that means this is almost likened to a hospital care, wherein we are already aiming to reduce the symptoms and improve the quality of life upon diagnosis. And this is where the nuclear warheads come into the picture. That is incorporating systemic treatments into the management strategy. After all, the problem that we see is a low filaggrin expression on the skin. So we again know what are the implications of this outstanding issue of an eczematous skin, of an atopic skin. Number one, this is potentially an indication that there will be an early onset of atopic eczema and a persistent atopic eczema. There is also a likelihood that there's a risk of a development of food allergy later on in life and an allergic sensitization. There's also that increased risk of asthma. But somehow we see that because of this, it is not a surprise that we will see a more severe type of atopic eczema. And we know that with that severe type of eczema, and what happens on a cutaneous level, it is not a surprise that that skin is more prone to developing infection, from bacterial to even viral infection. And this is the bacterial infection, which is also creating a dysbiosis, which further drives down the skin to become disrupted. And finally, we know that cirrhotic skin alone becomes more dried out, lower natural moisturizing factors, and an increase in skin protease activity, which creates a breakdown of the skin cells, creating an eczematous skin. So again, prevention. Primary, intervening before health effects occur. Secondary, when you are detecting a condition at an early stage to prevent worsening. And finally, tertiary prevention. We try to reduce the symptoms or improve the quality of life upon diagnosis. And that means we step into the picture, the healthcare providers, the attendings of these patients. So let's see, can we possibly do some microbiome modulation? So long ago, this was not thought about. It was something like we just thought of atopic eczema. Yeah, so it's teeming with Staphylococcus aureus and it stops with that. But what can we do? Staph aureus exerts its pathogenicity on the atopic skin, causing barrier disruption and inflammatory changes. But look, you know what's interesting now? There is a study that is looking into transplanting cultured coagulase negative staphylococcus, such as the staph epidermidis and the staph hominis, which is capable of tempering down or inhibiting the staph aureus growth by antimicrobial peptide secretion, which causes the decrease of this pathogen in patients with atopic eczema. The clinical efficacy was not assessed in this trial, which opens a window for further investigations. And now you will see something that I hope you have finished your dinner, but they're looking into the possibility of using fecal microbiota transplantation. Yes, you heard it right. You read it right. Fecal, as in poop, as in the yellow soup that has been in existence even during the century-old China type of medicine. So in mice, fecal microbiota transplantation is associated with normalization of the Th1, Th2 cell imbalance and a decrease in levels of IgE, circulating eosinophils, and skin mast cells in relation to lower clinical dermatitis response. So let's go back to the basics. We know since already moisturizers have already created the deep niche in controlling or trying to prevent atopic dermatitis. And yes, it is still part of the consensus statement that basic management of atopic eczema, you need appropriate application of moisturizer because this will assure adequate hydration of the skin cells, improve barrier function, and decrease insensible water loss, therefore bypassing the skin to become dried out. And look, moisturizers absolutely are a primary therapy for atopic dermatitis. And these are two studies that would support, but this was in 2014. One was by Horimukai, and the other was by, this is the early study of the BEEP study, that is barrier enhancement for eczema prevention by Simpson, but this was in 2014. And it is in these two studies that showed that the moisturizers had a positive effect in trying to prevent the onset of atopic eczema designed to and the moisturizers were designed to maintain skin barrier integrity through emollient application. So what came out of these studies is that there is a percentage of patients who in the moisturizer group compared to the control group did not develop atopic eczema. But now of present, this is now where it gets interesting. The Prevent AD All, Preventing Atopic Dermatitis and Allergens in Childhood study, and also Chalmers BEEP study of 2020, sadly said otherwise, indicating that it failed to meet the endpoint of preventing atopic dermatitis. Now, in this Cochrane study, 33 RCTs concluded that studied skincare interventions during the first 12 months of life, including emollient application, were not effective at reducing the risk of eczema, but it increased the risk for skin infection and may increase the risk for cow's milk allergy at age 2 years. However, the evaluation of emollients as a whole through systematic review is challenging and possibly inadequate given considerable heterogeneity in the emollients studied, emollient specific properties, and in RCT design. And about this statement, there are some investigators that are thinking of the possibility of contamination of the emollient that was utilized on these patients. In this study as well, the emollients in infancy to prevent AD, a systematic review and meta-analysis, the prophylactic and continuous application of emollient on infant skin may prevent AD in high-risk populations and when used continuously. So it's not a totally demolished idea that it could prevent the onset of atopic eczema. So we see the big three of the natural moisturizing factors. We have ceramide, we have cholesterol, and we have free fatty acid in this ideal molar concentration that would create the ideal natural moisturizing factor on the skin. And with Peter Elias, he has indicated that as a preventive remedy, ceramides, which is a physiological lipid, are quickly absorbed into the underlying nucleated cell layers, which they incorporate into lamellar bodies. The pH abnormality of the AD skin is corrected, and it enhances epidermal production of the key antimicrobial peptide LL37. Here's another thing to look at: water softener installation to prevent AD. We know that hard water contains greater concentrations of calcium carbonate and magnesium carbonate. And aside from the presence of sodium lauryl sulfate detergent deposition on the skin, changes in calcium signaling pathways in epidermis and increased skin pH will increase the protease activity of the skin cells and cause further breakdown of that skin. Now, in the SOFTER trial, which stands for Softened Water for Eczema Prevention trial, they explored the impact of water softener installation at home on eczema onset during the first 6 months of life. And in this small trial involving 80 randomized participants, 33% of infants with household water softeners installed developed eczema by 6 months, compared to a larger percentage of the infants who were in the control group that did not contain any water softener. What about the probiotics? It is a microbiome-based prevention to influence postnatal gut microbiome. Now, the lactobacillus supplementation is associated with a variable enhancement of Treg populations and of inhibitory cytokines of interleukin-10 and TGF-beta and dendritic cell maturation. Coelho, Garcia et al. Showed the role of probiotic supplementation in allergic disease prevention, and there was a mild reduction in AD was observed when oral probiotics were used by the pregnant or breastfeeding mothers or as supplementation among infants. And in the 2018 meta-analysis study paper, there was a primarily involving at-risk patients revealed a mildly protective role of oral probiotic supplementation in the prevention of eczema. So what are the future insights in primary prevention? There are difficulties inherent to the prevention studies. There's the necessity to identify a high-risk cohort in infancy or before birth, and without the biomarkers to define risk status, clinical trials will need to be very large to reveal success, which makes progress both slow and expensive. Now, in this Sunbeam study, which is an ongoing multi-centered COFAR prospective birth cohort study designed to evaluate for the onset of IgE-mediated food allergy and atopic eczema from infancy to 36 months. They wish to identify the biomarkers and risk factors that may facilitate more efficient design of future studies, in addition to identifying environmental risk factors that could guide potential interventions. So we look at the entire landscape of an atopic eczema problem. We know that a barrier impairment due to filaggrin in mutation can lead to allergic sensitization and will lead to atopic eczema development. And we see the importance of the emollients in trying to prevent this, in trying to create homeostasis of the microbiome, in creating as an adjunct therapy of topical anti-inflammatories. Especially we want the corticosteroids out of the way as soon as possible. And to a certain extent, this will also prevent the possibility of the patient going into the atopic march, developing asthma or food allergy. Now, secondary prevention again deals with the patients who will likely develop asthma. But just to shortly mention about it, they treat the AD aggressively when it first appears to avoid the patient to go into the cadence of the atopic march. And the ETAC study showed that cetirizine might inhibit eosinophil effect to the lungs, but it did not show asthma could be prevented. And when it comes to the tertiary prevention, this means disease treatment, prevention of deterioration, and disease complications and sequelae. When considering prevention of flares, consider induction of remission before proactive therapy is initiated. So we get control, then keep control. So after all, we want this barrier to be patent and not compromised. We try to avoid this. We try to prevent this. So if we look at this, how we can do a prevention steps in managing skin barrier dysfunction, still we go back to basics. We look at which is the best skincare barrier approach. Do we use lipid-rich creams? Do we use the occlusives, the petrolatum-based emollients, or do we do the targeted therapies? And when it comes to the intermittent intervention for onset of overt skin inflammation to resolve the rashes, yes, we still need the topical anti-inflammatories, whether they are the corticosteroids or the calcineurin inhibitors, or the topical PDE4 inhibitor. This is the crisaborole. The proactive treatment, again, we need the help of the calcineurin inhibitors or the corticosteroids, but we need to avoid the triggers as well. It is more about the heat and the sweating here in our environment, and also protection from the pollution. But don't just think of the pollution, even inside the house where we are at right now, think of the volatile organic compounds, just like the diffusers that we buy from the department stores, just like disinfectants that we keep on spraying around. And finally, some those that are in the experimental stage, hopefully one day we will be able to make use of a, who knows, filaggrin gene cream. So with this, you don't want this. Our aim is to do this, to get to this. It may not look perfect at all. This is after a few days of emollient therapy and some help of the anti-inflammatories, because after all, we want the patient to eventually get into that stage of remission. So there has been an explosion of new therapies directed at addressing the inflammation, and not all patients will have access to the new targeted therapies due to its unavailability, territorial unavailability, or even the steep price of the drug. We still go back to basics. Prevention is reasonable and cost-effective. And moisturizers, especially lipid-based emollients, are effective and vital adjuncts in eczema management. And with that, I thank you for your kind attention.
Thank you very much, Dr. Maria Victoria C. Dizon, for that insightful lecture. We encourage everyone to type all their queries in the chat box and we shall discuss it during the Q&A session later. Please wait for the QR code to be flashed at the end of the program to access the webinar quiz. A kind reminder to please stay at the end of the webinar and complete the evaluation form and short quiz to be able to earn your CME credits and certificate. Let us not further delay. I'm sure we are all looking forward to our next lecture. Our next speaker will take us through unfolding infections and atopic dermatitis in the last decade.
Good evening. Today, I will be talking about unfolding infections and atopic dermatitis in the last decade. Atopic dermatitis affects both children and adults with a prevalence of up to 18% and 7% respectively. Patients with atopic dermatitis and their caregivers experience decreased quality of life, including disruption in daily activities of school and at work, sleep disturbance, depression, and anxiety. In addition to these complications, patients with atopic dermatitis are in increased risk for infections. The prevalence of cutaneous and systemic infections in patients with atopic dermatitis is significantly higher than those without atopic dermatitis. Why is there increased infection in atopic dermatitis? Skin barrier defects, immune dysregulation, Staphylococcus aureus colonization, and dysbiosis of skin flora. So for patients who have atopic dermatitis, they are inherently associated with a skin barrier defect as measured by transepidermal water loss. And we know that they have greatest transepidermal water loss, especially in those with severe atopic dermatitis. Patients significantly have a thinner stratum corneum, and the molecular basis for skin barrier defects is due to a deficiency in proteins and lipids with barrier functions, including filaggrin, involucrin, claudins, ceramides, and free fatty acids. They're also deficient in chemical barriers like beta-defensin 2 and catholicidins. The first genetic basis of skin barrier defect in atopic dermatitis is the filaggrin gene loss of function. They are very also susceptible to environmental insults like allergens and pathogens. They're associated with early onset of atopic dermatitis. In fact, it has also been noted that it's present in 25 to 30%, those with European and Asian descent. Atopic dermatitis with the filaggrin gene loss of function was noted to have 7 times higher risk and greater than 4 times requiring antibiotics within a year. They're also high risk for eczema herpeticum, which is a viral infection in patients with atopic dermatitis. In healthy skin, we note that the filaggrin is broken down into amino acids and maintain an acidic pH of the skin. There's also a decreased expression of staphylococcal surface proteins. However, in those with a defect in filaggrin, they have decreased amino acids, a rise in pH, and they favor staphylococcal proliferation. How about immune dysregulation? It has been found out that in atopic dermatitis, the keratinocytes produce an increased amount of thymic stromal lymphopoietin, interleukin 33, and interleukin 25. These activate to produce type 2 cytokines, plus interleukin 4 and interleukin 13, which suppress keratinocyte expression, leading to infection. And also, we need to talk about Staphylococcus aureus colonization. Up to 90% of AD patients are colonized with Staphylococcus aureus. The predominance of aureus is unique to atopic dermatitis as compared to healthy individuals and other chronic inflammatory diseases like psoriasis. They also produce enterotoxins, or what we call superantigens, that breaks down the skin barrier and enhance type 2 inflammation. These superantigens also downregulate interferon gamma and tumor necrosis factor alpha, which are important mediators of cellular immunity against bacterial and viral infections. Here is a diagrammatic picture showing you Staph aureus, okay, when you have enhanced Staphylococcus aureus colonization in atopic dermatitis, which is noted to increase, and then you have an epidermal barrier dysfunction that occurs. So you have your filaggrin mutation, increased pH, again, and decrease of your lipids. So staphylococcal enterotoxins stimulate cell responses, and there's an interleukin 31 expression. Note that your interleukin 4 and interleukin 13 play a major role that drive that inflammation in atopic dermatitis. Another diagram here further explaining to you what happens when you have Staphylococcus aureus colonization. This in atopic dermatitis, your keratinocytes produce an increased amount of your thymic stromal lymphopoietin, which I mentioned earlier, and then increase in your interleukin 4, interleukin 13, which suppress again your keratinocyte expression, okay? And these actually leads to antimicrobial peptides and disrupts that skin barrier function. Lastly, let's talk about the dysbiosis of your skin flora. We know that most abundant microbes are your Cutibacterium acnes, your Corynebacterium, and your coagulase negative Staphylococcus. And patients with atopic dermatitis are deficient in this commensal bacteria. What is the importance of your commensal bacteria? The role is to modulate host immune system, minimize inflammation, and increase protection against microbial pathogens. So let's talk about these bacterial infections. Your impetigo, your cellulitis, and your skin abscesses are common skin soft tissue infections in atopic dermatitis. And the most common cause of these infections is your Staphylococcus aureus. Impetigo, which typically presents with an oozing serum that has dried up, giving a crusted appearance surrounded by an erythematous base. Then you have your focal erythema swelling, warmth, and tenderness are signs of your non-purulent skin infection like your cellulitis. Some patients may experience fever and bacteria. Then you have your purulent skin soft tissue infections as your skin abscesses, which may be fluctuant or non-fluctuant nodules or pustules surrounded by an erythematous swelling. Note that your methicillin-resistant Staphylococcus aureus is also a common cause of these lesions. So this may lead to systemic complications like your bacteremia, osteomyelitis, your septic arthritis, your endocarditis, and your staphylococcal scalded skin syndrome, where you have widespread desquamation. Markers also, you have persistent elevated inflammatory markers, such as your C-reactive protein and your erythrocyte sedimentation rates, further increase index of suspicion for these infections. How do we prevent infections in atopic dermatitis? It's very important, your daily skin hydration and moisturization. Of course, the choice is dependent on patients' or parents' preference. In general, a thicker ointment based moisturizer may be very good. Of course, choose the unscented hypoallergenic moisturizers. Your topical corticosteroids or your topical calcineurin inhibitors for eczema areas, and your emollients as maintenance for unaffected areas. So it's very important to improve that skin barrier function based on transepidermal water loss and decrease Staphylococcus aureus colonization in your AD lesions that are even associated with increased microbial diversity. So here's again diagrammatic picture showing you what happens when you put in that anti-inflammatory therapy. So the increased level of your interleukin-4 and interleukin-13 is downregulated, as well as these antimicrobial peptides, which can trigger, host damage because of the Staphylococcus aureus infection. What else should we? Personal and household decolonization, is likewise important. Nasal decolonization with your intranasal mupirocin. Topical decolonization with your dilute bleach bath. Another alternative can be your chlorhexidine gluconate, although preferred is your dilute bleach bath because as a wash or as disposable wipes, because this can induce your chlorhexidine washes, can also induce skin irritation. But if you have recurrent infections, personal environmental hygiene, and also for recurrent episodes, your topical decolonization and dilute bleach bath can be maintained twice weekly. How do we manage infectious complications in atopic dermatitis? Approximately 20% of children with AD are hospitalized due to their bacterial infections. So you can give your beta-lactam antibiotics covering your Staph aureus and your beta-hemolytic streptococcal infections, and your empirical antibiotic. Of note that for critically ill patients, be known to cover them for both MRSA and your methicillin-sensitive Staph aureus. So for your MRSA, you can give your vancomycin, your clindamycin, doxycycline, trimethoprim, sulfamethoxazole, and your linezolids. For your methicillin-sensitive, your napsilin and cefazolin. Of note that duration of therapy must be an average of 7 to 14 days. Clindamycin are all acceptable options. Rates, although note that rates of clindamycin resistance have been rising among both MRSA and methicillin-sensitive Staph aureus nationally. How about for viral infections? So here you have a characteristic lesion, sudden onset eruption of monomorphic vesicles and punched out erosions with hemorrhagic crust over an eczematous area. They may have fever, lymphadenopathy, or malaise. Presentation may be mild and self-limiting to life-threatening in children and immunocompromised patients. So this is your eczema herpeticum. Eczema herpeticum is caused by an infection with your HSV1, which is potentially life-threatening infectious complication in patients with atopic dermatitis. It's seen in younger age and non-white race have an increased risk, like your African American, Asians, and your Native Americans. The skin can be pruritic, there may be pain. Of note that the lesions have vesicles, punched out erosions, and they may also have hemorrhagic crust. There also is a systemic variant showing you these changes. And here showing you what happens when you have factors promoting HSV replication in eczema herpeticum. So note that in your atopic dermatitis, aside from your staph aureus, they're also characterized by an impaired skin barrier, especially a filagreen and claudine deficit. An abnormal immune response is found and includes overexpression again of your type 2 cytokines, such again as your interleukin 4 and 13 and other inflammatory mediators. And these again, cytokines lead to lower induction of antimicrobial peptides that is seen in other inflammatory skin diseases and exacerbates again that skin barrier defect. Okay. So in eczema herpeticum, exposure in HSV1, 60% in adults, 20% in children. Okay, the immunologic and genetic elements actually in atopic dermatitis contribute to the vulnerability of a subset of these patients. So note that patients with atopic dermatitis and eczema herpeticum have a reduced interferon gamma production, more severe AD and earlier onset of AD. They may also have a high total serum immunoglobulin E and high peripheral eosinophils. Again, in eczema herpeticum, this is associated with secondary staph aureus infection in patients with atopic dermatitis. How do we manage this? Treat it with your systemic antivirals. Should not be withheld. There may be a co-infection of your Staphylococcus aureus, which is very common. So here showing you how to treat for mild, severe, and critically ill patients. So do give your oral acyclovirs. Of course, warn them the risk of autoinoculation and frequent hand washing is really encouraged. Contact precautions are also initiated and monitor for the development of secondary infection. Here is a table also showing you suggested doses for adults with eczema herpeticum and the pediatric dose, okay, for your antivirals. How about, what is this eczema coxsackium? This is similar to your eczema herpeticum. So it was first coined as early as 1968, where you have generalized varicelliform eruption, again in a patient with atopic dermatitis, after infection with Coxsackie virus A16. So in 2012, it was described that the CDC reported patients with severe hand, foot, and mouth disease. Plus, they noted an atypical rash that mimicked eczema herpeticum. And this outbreak was associated with Coxsackie virus A6. And in 2013, they noted, okay, an article on severe hand, foot, and mouth disease associated with Coxsackie virus A6. So this is your typical hand, foot, and mouth, where you have vesicles on the hand, on the palms, the soles, sometimes with oral ulcers. But here you have more florid cases of these lesions, okay, and also around the mouth, periorally. So this has been described as your atypical exanthem from your classic hand, foot, and mouth. They presented with vesicobulous erosive lesions, eczema herpeticum-like eruption, which we call now eczema coxsackium. Sometimes the eruptions were similar to a geonotic crusty-like or petechial and purpuric eruption. So here are photos showing you of those cases that have been reported, the vesiculobulous eruption, almost mimicking like your bullous impetigo. And then you have here severe lesions on your atopic dermatitis areas, okay, showing you that vesicles. Of note that in these cases, suggestive of hand, foot, and mouth, they presented with fever, oral erosions. Some had mild gastrointestinal symptoms and oral vesicles on hands and feet, and they have been in contact with somebody who was sick previously. So these are the features that will link you to a Coxsackie virus A6, and I wanted to describe to you the eczema coxsackium, where you have vesicles and erosion in areas of eczematous dermatitis. So this is caused by your Coxsackie virus A6 and A16. They grow poorly in culture. So diagnosis here is purely clinical. It's seen in preschool children. There may be fever, sore throat, and they may have poor appetite. But this is actually non-life threatening, and it's more common in children. So of note that the mechanism is similar to eczema herpeticum, where patients have an impaired immunity to the virus and barrier dysfunction. Okay. So vesicles are monomorphic. Some may be painful, but they're not pruritic. Any site can be affected. So the course actually of the illness is similar to your hand, foot, and mouth. You may also have onychomadesis, or the shedding of the nail, in 30%, but this resolves with complete nail growth. How do we manage this? We manage this with eczema, wet wraps, and low-potent topical corticosteroids. Your systemic steroids are avoided. You can give supportive treatment. There's no vaccine against Coxsackie virus, and general efforts are your hand washing, sanitation of surfaces, and avoidance of sick contacts. Another virus is your pox virus. This is your molluscum contagiosum. So again, there's a skin barrier defect that predisposes these patients. And the molluscum and atopic dermatitis is associated again with this filagreen gene loss of function. Of note that it's the third most common viral skin infection and the fifth most prevalent skin disease worldwide. So it affects children, 1 to 14 years of age. It can also affect older individuals who are immunocompromised and sexually active adults. Okay. What is the impact on the quality of life? Of course, we want to identify first. Look for the primary lesion. Umbilication is what we tell our residents, but it does not always occur. Lesions are not usually super infected, but when you're unsure, then do your cultures. Look for that molluscum in the center, and the time course average is around 18 months. So lesions may be mistaken for your bacterial infections like your furuncle, cellulitis, but the purulent material here is usually sterile. Superinfection with your staph aureus can occur, but is very rare. It represents a cell-mediated immune reaction to the molluscum virus. So here, you see your typical molluscum contagiosum with your molluscum body, and then here you see a little irritation. What do we call that? That is the beginning of the end sign. When you have already erythema, this represents the body recognizing the virus and starting to fight it. So when you see that, you usually no need to start your topicals or systemic antibiotics. Just reassure the patients. Try to avoid use of your topical calmiciptins, caladrils, Lucas papaw are also not recommended because these can cause a form of contact dermatitis. We have what we call molluscum dermatitis, and this is seen more often in patients with AD. And if severe, you treat with your topical corticosteroids prior to treating your molluscum. But of course, don't forget to use liberal use of your emollients. So as we noted, molluscum contagiosum is a defect in the generation of your antimicrobial peptides. So here, your typical molluscum dermatitis. More pictures showing you. Then recently, we have a description of a Giannotti-Crosty syndrome-like reaction to molluscum contagiosum. These are, and what is this? This is what we call Giannotti-Crosty-like reaction. So from your typical, just to refresh you of your Giannotti-Crosty, it's caused by your Epstein-Barr. It's monomorphic. You see papules. They're more generalized. Okay, and also the pruritus may be slighter absent 6 to 10 weeks. As compared to your Giannotti-Crosty-like reaction, a trigger is your molluscum contagiosum. They're usually polymorphic. They're relatively localized, okay, predominantly over extensor surface of larger joints, elbows, knees, Achilles tendon. The pruritus may be more severe, but their response to your topical corticosteroid treatment is very good. Gianotti-Crosty, typical Gianotti-Crosty syndrome. And again, your Gianotti-Crosty syndrome-like reaction, okay, monomorphic-like reactions, mainly on the extremities, duration is 6 weeks. So here are photos showing you that Gianotti-Crosty-like reaction, more on the extremities, on the elbows, knees, okay. And then here's an actual patient showing you initially molluscum contagiosum with that typical Gianotti-Crosty-like reaction, again, on the knees and extremities, few on the buttocks. So what is the trend in treating? Let's go back to treating your molluscum. Rely on its self-limited nature, reassurance. Okay, and how do we reassure them? We know that they may persist beyond 18 months and 13% will persist beyond 24 months. So household transmission is less than half. Not a big impact actually in quality of life, although 11% were associated with a marked decrease in their quality of life. No treatments up to this date is FDA approved, and there's no consensus on the optimal treatment of molluscum contagiosum. But can we do conservative treatment? Lesions in healthy people are typically self-limited, okay, although for the non-genital lesions, you may provide treatment. So our moral, what we need to remember is first, do no harm, the Hippocratic Oath, and you can give your keratolytics. Of course, treatment is guided by the age of the patient, the lesion location, anxiety more for the parent rather for the patient. No? Every doctor believes that their treatment is the best. So your treatment options is you want to eradicate these lesions, you want to minimize pain, avoid scarring, and prevent recurrence. So here's a table showing you the different methods of the treatment options. And the favorite therapy of your pediatric derm in the office is we have cantharidin, which is our gold standard. Okay, we tell our patients to expect blistering, although nowadays it's very difficult to access cantharidin preparations. And if we're going to talk about infections in the last decade, it won't be complete if we won't discuss COVID-19. COVID-19 was initially recognized symptoms were respiratory culminating to severe respiratory distress requiring ventilation and causing death in a percentage of the population. So they presented as acral ischemic lesions similar to chilblains, and then lesions were more common in adolescents and young adults. It commonly involved toes and feet, less frequent the fingers and hands. Some had erythematous violaceous swellings and dark purpuric macules. So here are photos of those chilblain-like lesions, the spectrum of acral ischemic lesions in children in the setting of COVID-19. And then there were also erythema multiforme-like eruptions, typical target and targetoid-like lesions. And urticaria occurred in 10 to 20% of patients with skin lesions in COVID-19, and its incidence may be underestimated in children. So other forms as well of exanthems whose relation to COVID-19 is unknown and have been reported during the COVID-19 outbreak. These include purpuric rashes, maculopapular exanthems, pityriasis rosea-like eruptions, and oral findings, among others. So here you have the erythematous exanthem and the purpuric rash. There, the purpuric rash that you can see. Okay. And this is actually the algorithm for diagnosis of COVID-19 in children with a skin eruption. Okay. So just sharing to you this table, they had fever greater than 38 degrees, muscle pain, headache, some had asthenia, cough, dyspnea, nausea, vomiting, diarrhea, anosmia, ageusia. So how about COVID-19 and atopic dermatitis? So the European Task Force on AD made a statement. They advised patients to continue actually all medications, observe hygienic measures, moisturize skin regularly, and if systemic treatment is discontinued, replace this by your topical therapy. Dupilumab, which will be discussed, was preferred over other medications and was very important to provide access to telehealth. So in summary, atopic dermatitis is a complex disease with skin barrier defects that cause a vicious cycle of inflammation, and prevention of infections should emphasize that repair of that skin barrier. Daily skin hydration and moisturization are very basic and highly recommended. And it's essential to identify these infections since in atopic dermatitis patients to be able to address treatment and avoid further complications. There is so much upcoming research and studies that will target type 2 inflammation that will also benefit our patients with active infection. And these are my references. And thank you, and let's all stay safe. Have a good evening.
Thank you very much, Dr. Donna Marie El Sarosa, for extending your knowledge with us through that informative lecture. We encourage everyone to type all their queries in the chat box and we shall discuss it during the Q&A session later. Please wait for the QR code to be flashed at the end of the program to access the webinar quiz. A kind reminder to please stay at the end of the webinar and complete the evaluation form and short quiz to be able to earn your CME credits and certificate. At this point, it's time to discuss some learnings, realizations, and find the answers directly from our speakers. They will be joined by our guest moderator for this summit. Our moderator is the Chief, Section of Dermatology, the Medical City, an active consultant at the Department of Dermatology at the UST Hospital, a professional lecturer at the Ateneo School of Medicine and Public Health, the Treasurer of the Pediatric Dermatology Society of the Philippines, a founding member of the Pediatric Dermatology Society of the Philippines. Let us all welcome Dr. Maria Lourdes H. Palmero.
Good evening, everyone. Thank you for joining the Pediatric Dermatology Society of the Philippines for AD Summit 10.0. We are truly fortunate to have heard the excellent lectures of Drs. Donna Sarosa and Dr. Mary V. Dizon. So now, may I invite Drs. Dizon and Sarosa to clarify issues and unanswered questions from their lecture. So we now have 15 minutes actually to pick on the brains of these two distinguished pediatric dermatologists. Okay, so there are actually a lot of questions in the Q&A box, so I'll synthesize some of the questions, I'll put them together, and I'll start off by asking Dr. Dizon first. So there are common questions here. So are the biologics and crisaborole available locally?
All right. Good question. And that is precisely why I am emphasizing the fact that we have a problem here in managing patients, especially the severe ones. Unfortunately, we do not have the dupilumab, the lifesaver of all severely atopic patients. The nearest territory that our patients can go to is Singapore. But if and of course the other countries that have it, of course, without question, the US. But if there's one thing that I want to deliver a message to everyone, do not attempt to bring in the dupilumab. Because of course there are some patients who already wanted to do that. You have to keep in mind that there is a cold chain storage. This is no different from your COVID vaccine. It's not that easy to bring that in. You may file for a compassionate use purpose, but again, do not attempt to bring it in like it's in your hand carry. So the biologicals that are available here are the oral biologicals, which are being utilized by our rheumatologists. They are making use of the baricitinibs, and but for use of the baricitinibs or the JAK inhibitors is already have studies being published already for use in adults. Now, for children, it's still undergoing studies as to how to properly administer the drug to the pediatric age group. But uh, we only have the JAK inhibitors here, not the dupilumab.
Okay, so thank you for that clarification. So let me ask a question for Dr. Sarosa. So there are questions about bleach bath. So one question is how to prepare the right combination for the bleach bath. Another question is a swimming pool good enough as a bleach bath? So maybe you can address those questions.
Okay, so basically, in my talk, I was telling you about topical decolonization. And it's very important that you do the application of your topical 2% mupirocin together with your decolonization, so your bleach bath. How do you prepare this? The proportion is quite big. So you can use 1 teaspoon of your regular Clorox to 1 gallon of water. If you have a bigger tub, it's 1/4 cup of bleach to 13 gallons, which is quite a big number of water. I used to do a modification, and you would still compute a 0.005% concentration, which is what? 1 ml of your concentrated Zonrox, your bleach, plus that's 500 ml or 2 cups of water. So that's and I would call that an improvised, like a small pail method. So that's the tabo, because we don't have, these big, uh, big tubs
Tubs.
like they would describe it in Western countries. Now, comparing swimming pool water and the bleach bath, almost maybe about the same, but you don't want to put your kid who has that, like an infection, putting them in the water and then getting them out of the pool for 15 minutes. So basically, that's the proportion.
Okay, so thank you for that. Another question for Dr. Sarosa. So there are actually 3 questions for the viral illnesses in atopic dermatitis. So I'll put them all together. So for eczema herpeticum, what is the usual dose for children? Second, is eczema coxsackium something that's similar to eczema herpeticum, that it becomes recurrent? And there's also a question about cantharidin for molluscum in AD.
Okay, so let me answer first the treatment for eczema herpeticum. I think there was a comment even there that the table might be a little too small because I wanted to put in the other kinds of treatment that are available for children and adolescents. So if you're going to give it orally, the dose for eczema herpeticum is 20 milligrams per kilogram per day, given 4 times. So your maximum dose should not exceed 800 milligram dose. Now, is it available, the suspension? Pharmacies can actually compound it into a suspension. So you can compute it by weight. And once that, or in hospitals as well, it can be given intravenously, but once they have improved, you can start giving it orally. So that's the dose. So like our tertiary hospitals, they have the suspension available. Your next question was recurrence, right? From
Yes.
coxsackium and eczema herpeticum. Yes, because they are viruses, you don't get permanent immunity. So you can have recurrent episodes, but if you do have, you may have to check the immune system of the child. Why are they getting, recurrent viral infections as well? Now, for cantharidin, as I mentioned, this is not something that's available or highly accessible even amongst dermatologists and even us pediatric dermatologists. It's actually manufactured by Dormer Laboratories in Canada. And you'll be surprised, during COVID, they they were also out of stock. So, it's very difficult, but if we have it, it's highly effective. There's also a new preparation of cantharidin that's being available now in the US, but it's quite expensive. I think it's triple or four times the cost of even the cantharidin preparation. So there are lots of alternatives to treat your molluscum contagiosum.
Okay, so thank you for that. Can I call on Dr. Dizon? So there is a question about modifying the diet of mothers especially for breastfed infants. Is there a role for that? And the other question is, in relation to that, testing for food allergens or food intolerance in AD patients, is that something that you would also recommend?
Okay, I will touch first on the second question, the food allergens. That's a very tricky thing to be doing to atopic patients, and uh, it's also worthy to work together with our allergy and immunology colleagues, our colleagues from the Philippine Society of Asthma and Allergy and Immunology, PSI. But otherwise, um, there are certain steps that you can do before they carry out the testing, but let's just make it simple. A food diary would be very helpful. Now, not unless you now see like a highly probable correlation of what the patient eats, and it depends on how many the timeline, that is how soon or after how many hours the patient breaks out with a allergic manifestation. So but the testings, the problem is if it comes out negative, the the tendency of the parents or the patients is to veer away from that food when actually they are not allergic to that food. So essentially now they are getting malnutrition or lack of nutrition because everything that comes out positive, they just stay away from it. So um but bottom line, I would say that instead of you handling it, I strongly recommend that you refer to our allergologists, to our allergist colleagues, and help uh, help work with them when it comes to food, suspecting food allergy.
So thank you, Mary V, for that. The other question is there a role for modifying the diet of
Ah, yes. Okay. So modifying the diet of the mother. All right. Everything again boils down to what can we do with the gut microbiome. So now it's a matter of what is circulating in the mother will now translate to what is going into the fetus. And the thing now is we are now realizing this landscape of the medicine in microbiome, in the sense that it now we are trying to settle down the ideal microflora that will be in the gut. So what the mother is taking might also translate to what is primarily in the gut, will later on be in the gut of the infant, now of the fetus. So but and when the infant is delivered, is born, the breastfeeding is again the best nutrition an infant would get, because that also shapes the microbiome that is going to proliferate in that gut. And whatever happens in that gut already, we see that it impacts the general health of a patient, from the psychological state to the growth of the patient. But it now depends on how you will feed that infant once they're born. Breastfeeding again is the best compared to what's this milk formula, because what comes out of the breast milk also, the the gut microbiome of the infant is digesting properly the milk that is coming from the mother.
Okay, so thank you. May I ask Dr. Sarosa? So there's a question that was sent to me. How do you differentiate COVID-19 papulovesicular eruption from monkeypox eruption? So I think this is very relevant for now.
Yeah. In my actually talk, I wanted to put monkeypox, but at the time, it's something very new to us. In fact, we're all as dermatologists, when we see infected lesions at the back of our mind, our differentials is always right nowadays. Does this patient have monkeypox? Okay, so first and foremost, COVID-19 eruption is rare, although we've seen it and I've shown you some pictures. What happens is they're usually in COVID-19, they're usually asymptomatic, sometimes mildly itchy, and they lack that central umbilication that you may have in a pox virus. And the good news is they heal without scarring. And in contrast to our monkeypox, and that's why most of us are quite scared about it. And if we have spread of that, it's literature actually even says that they present with larger papulovesicles, and they're often tender. Of course, we always ask history of fever, lymphadenopathy, and if you look at the lesion, they say in literature that they're very firm. They're tough to the roof, so there has to be a specific way as well if you're going to send your specimen to RITM, and they have seldom a liquid content, which is what we see in herpetic infections. In herpetic infections, they're usually more liquidy. So that's maybe how to differentiate it.
Okay, so thank you for that. Another question for Dr. Dizon. So there are questions here about the topical. So for one, is there a role for topical nicotinamide and niacinamide? What's the best over-the-counter moisturizer? Okay, so those are two questions that I'd like you to address, Dr. Dizon.
The topical nicotinamide, niacinamide, apparently has been viewed as a better option than using petrolatum. So yes, it's also effective as a moisturizer. And now, if you ask, what can the parents or my patient go to easily as a choice of a moisturizer? Okay, let's just go to the basic principles of what is an appropriate moisturizer. Number one, it's practically fragrance free. Number two, it's depends on what your preference would be, lotion or cream. It again boils down to what's your patient's preference, because after all, you want your patient to comply, to adhere, not unless the problem is so difficult that you have to dictate to the patient that you're outright saying you have no choice but to get this. So but otherwise, it is something also wherein, all right, my basic principle is the patient will have easy access to that moisturizer, and the hospital pharmacy and the drugstores are always open. It has to be available there. So that is one very important thing that you have to remember. So what is a good moisturizer? Our group years ago came out with different kinds of moisturizers and categorizing the ingredients and the mechanism of action of the ingredients according to what's seen in that moisturizer. Now, I would encourage that it would be good that you read up on it, because I cannot say that this is the best moisturizers that out there. It depends now on you personally, what you think is good for your patient. In other words, you tailor make your choice according to what you feel your patient needs.
Can I make a comment also on the topical niacinamide and nicotinamide? I think we're more talking about, when they talk about those type of moisturizers, maybe for adolescents or maybe more mature skin, like we would use it for acne, for, let's say, even sometimes for pigmentary changes, right, and rejuvenation. But for atopic dermatitis patients, especially in children, I would go more maybe for the filagreen-based moisturizers, the ceramide-based, where you have free fatty acid. Well, those are my go-to more moisturizers than, because I still want to, we want to prevent like early onset as well of contact dermatitis, especially in children.
I agree.
Okay, so thank you for that. In the interest of time, I'll ask two more questions, one for Dr. Sarosa and another for Dr. Dizon. So the last question for Dr. Sarosa. So when do we need to hospitalize atopic dermatitis patients?
Oh, so there's no hard and fast rule. There's no algorithm for hospitalization. I guess when you're not seeing improvement, you're seeing deterioration of the skin, you're not seeing also like some parents and caregivers, they don't know how to manage like emollient therapy. Maybe it can be a way of showing them. Of course, when you're already suspecting as well that there's secondary infection that they may need not only oral but even IV administration of your antibiotics for secondary infection. And I guess then that's when you do hospitalize these atopic dermatitis patients, but rarely. So of course, there are also other cases where they may have other signs like immunodeficiency where they have to be worked up. Then I guess they may also have to be hospitalized.
Okay, so thank you for that. For Dr. Dizon, how do you address pruritus and atopic dermatitis? Does Montelukast have a role?
Yeah, we tried Montelukast long time ago, even when I was still in Chicago, and the effect of it is not very convincing. So there are some colleagues who like using it. I personally do not use or prescribe Montelukast, not because I don't believe in it, but um, I would say that when it comes to the pruritus of atopic eczema, it's a very tricky avenue because it is, well, one, it is not truly it's not really truly histamine related. So if ever we make use of the antihistamine, it's because it's just like something that we want to sedate them at night, and in the hope that you would be able to rest that skin from the claw, from the scratching of the patient, whether it's a kid or an adult. But otherwise, the pruritus would be all right. Still, the topical corticosteroids are helpful. It's at times we need to utilize also effective emollients. After all, the emollients, the moisturizers, especially those that are ceramide based, they also help address the pruritus. So if ever there's something that I always emphasize on, don't forget your moisturizers. You can always forget your cell phone, but not the moisturizer. It's to create that impact, that strong impact of how important the moisturizers are. But again, I just have a strong statement for the effect of the moisturizers in helping relieve the pruritus. Also, if you can put the moisturizer in the refrigerator so that when it's applied on the skin, the cold effect tempers down the itchiness.
Okay, so thank you for that. So it's been a very productive panel discussion, but we have to end at this point. So Lastly, I'd like to remind the attendees to be present for Day 2 of AD Summit 10.0, a decade in review. So we'll see you all tomorrow. Thank you once again, Dr. Donna Sarosa and Dr. Mary V. Dizon for your excellent lectures and for your inputs on the management of atopic dermatitis. So thank you once again. Enjoy the rest of your evening.
And that concludes our panel discussion for this evening. Thank you for the enriching exchange of knowledge from Dr. Maria Victoria C. Dizon, Dr. Donna Marie L. Sarosa, and Dr. Maria Lourdes H. Palmero. To formally end our program and virtual gathering this evening, here to give us some words of inspiration and wisdom is none other than the head of Subspecialties Cluster, Philippine Dermatological Society, Dr. Blossom Tian Chen.
Okay, sorry, forgot to unmute. So I'm so excited to greet everyone. So good evening to all. Congratulations to this superb team, our esteemed speakers, Dr. Marie V. Dizon, and Dr. Donna Sarosa, for sharing your all your knowledge and expertise. And of course, to Dr. Madu Palmero for organizing all these interesting questions. Yes, Dr. Marivi, I heard you, your fecal microbiota transplantation. I can't wait to hear more from you in the next AD. And of course, our different levels of prevention, your primary, so interesting to hear about that water softener and all your other levels of prevention. Dr. Donna Sarosa, yes, thank you for reviewing all your risk and treatment prevention for all our infections. And very interesting to notice your molluscum contagiosum, since we see that a lot and it's really very frustrating. And and I forgot all about those molluscum dermatitis and your genotic crustioles, things we have to watch out for. So I'm sure we have so much to learn, even it's AD over and over again. There's always so much we can review and relearn, but not to worry. As Dr. Malu reminded you, we have another session, another interesting session tomorrow. So again, congratulations to the Pediatric Dermatology Society of the Philippines. I know how hard Mariel worked on all the papers, and of course to 10 years of AD Summit. Okay, good night to all.
And that wraps up our webinar tonight. Thank you, Dr. Chan and the rest of Galderma Philippines. We would like to extend our sincerest gratitude to our speakers, our sponsor, and to everyone who joined us in tonight's event. Please scan the QR code to access the webinar quiz. Please fill up the Google form with your details and answers to receive your CME points. Good luck! Once again, on behalf of Galderma Philippines, we thank all the attendees and participants for showing their support in this learning session. Please scan the QR code to access the webinar quiz. Please fill up the Google form with your details and answers to receive your CME points. Good luck! Once again, we'd like to thank you. Once again, Big thanks to Galderma Philippines, to all the attendees and participants for their support in this learning session. Remember to stay safe and healthy all the time. Thank you and good night.
75 years ago, Galderma launched a revolutionary product made by dermatologists for dermatologists. Cetaphil was formulated to care for sensitive skin. From the universal gentle skin cleanser, Cetaphil now offers an entire range of products that addresses specific conditions and skin needs. A legacy that has become our mission and purpose. Because skin sensitivity is more prone to skin issues like acne, hyperpigmentation, and atopic dermatitis. Our products draw on the latest in skincare science and research. At Cetaphil, we are advancing science for sensitive skin. Cetaphil cares for all types of skin, from oily, combination, and acne-prone. There's a product to help strengthen the skin barrier and protect and restore the skin. Cetaphil Gentle Skin Cleanser actively hydrates and preserves skin moisture with enhanced ingredients that was studied on 1,000 subjects and evaluated across 23 clinical studies. Cetaphil Oily Skin Cleanser cleanses oily skin without stripping it of natural moisture. The daily exfoliating cleanser is ideal for combination skin, gently exfoliating and leaving skin feeling refreshed and invigorated. While the gentle foaming cleanser cleanses without stripping the skin of its natural moisture balance. The Cetaphil moisturizing line address concerns about dry, very dry, and sensitive skin. With enhanced ingredients to improve skin quality, such as glycerin, niacinamide, and panthenol. Lightweight and fast-absorbing, the Cetaphil moisturizing lotion is clinically proven to completely restore the skin barrier. Women are prone to sensitive skin, but achieving a radiant, even skin tone is not impossible with the Cetaphil Bright Healthy Radiance range. Each product in the Cetaphil Bright Healthy Radiance range boasts of gentle bright technology. Niacinamide is one of the most accepted brightening ingredients among dermatologists. It improves skin evenness and the appearance of aging skin, while Sea Daffodil is an illuminating natural plant extract that reduces the surface and appearance of dark spots. 17 clinical studies with 739 subjects and 305 of them with sensitive skin have proven the effectivity of the Cetaphil Bright Healthy Radiance range. Cetaphil Brightness Reveal Creamy Cleanser removes dead skin cells, dust, and impurities to reveal skin's pure luminosity. Brightness Refresh Toner gives instant luminosity and hydration while softening and smoothing skin. In vitro studies prove how the Brightening Day Protection Cream SPF 15 does not only disrupt the skin barrier, but also significantly reduces skin pigmentation and provides anti-inflammatory effects. Brightening Night Comfort Cream works to correct dark spots, revive complexion clarity, and replenish skin's moisture. Brightness Reveal Bar leaves skin feeling refreshed, smooth, and noticeably radiant. Brightness Reveal Body Wash gently removes dirt, impurities, and dullness. And Brightening Lotion instantly makes skin smooth and hydrated. Up to 50% of children with moderate to severe atopic dermatitis have been seen to have a filigrein gene mutation, common features of atopic dermatitis. For those suffering from atopic dermatitis, there is Cetaphil Pro AD Derma Skin Restoring Range. Its patented filigrein technology provides eczema-prone skin with missing filaggrin, helping break down products and build a stronger skin barrier. Begin with Cetaphil Pro 80 Derma Skin Restoring Wash, which is formulated with a unique patented filaggrin technology that helps improve the natural moisture of the skin. Follow it up with the Cetaphil Pro 80 Derma Skin Restoring Moisturizer that has both filaggrin technology and ceramides to relieve and strengthen delicate skin. Its clinically proven formula replenishes moisture to help relieve very dry, itchy skin from day one. Baby's delicate skin has an ally with the Cetaphil Baby skincare line. Cetaphil Baby's gentle but effective skincare guarantees 5-fold protection for baby's delicate skin. Gentle, hypoallergenic, soothing, provides a moisture seal, and respects baby's natural skin barrier. Cetaphil Baby Gentle Wash and Shampoo with glycerin and panthenol cleanses from head to toe while providing daily protective moisturization. Cetaphil Baby Daily Lotion with shea butter deeply moisturizes baby's delicate skin. The Cetaphil Baby Gentle Cleansing Bar contains glycerin, which has anti-irritant properties to protect damaged skin. Cetaphil Baby Shampoo with natural chamomile is tear-free and gently cleanses the toddler's hair and scalp while restoring natural scalp protection. And reintroducing the Cetaphil Baby range with an added protection of organic calendula. Cetaphil Baby Wash and Shampoo and Cetaphil Baby Lotion's caring formula helps nourish baby's delicate skin. And the Advanced Protection Cream has soothing organic calendula, allantoin, and shea butter to reduce the feeling of irritation and discomfort of very dry, chapped skin. Today, Cetaphil offers a complete range of clinically formulated products to suit specific sensitive skin needs. Whether it's dry, oily, or acne-prone skin, hyperpigmented skin, or eczema-prone skin, Galderma complements a full spectrum of dermatology through consumer, prescription, and aesthetics medicine. We are Galderma, and we are advancing dermatology for every skin story.
Hi, my name is Dr. Mark Koh. I'm a pediatric dermatologist at the KK Women's and Children's Hospital in Singapore. I have been working with children with eczema or atopic dermatitis for the past 10 years. So to understand the treatment of atopic dermatitis, we really need to know the pathogenesis of the condition. Patients with atopic dermatitis have a genetic background which impacts the skin barrier as well as the immune system. And then environmental factors come into play, such as infections, allergens, climate, irritants, and even stress. Up to 50% of children with moderate to severe atopic dermatitis have a gene mutation in filigrein gene, leading to a decrease in the filigrein protein. Even in children with a normal filigrein gene, filigrein levels can be dysregulated by the inflammation caused by eczema. Filigrein is a protein that is a very important component of the stratum corneum, and it contributes to the skin barrier integrity and strength. It then breaks down into amino acids to form natural moisturizing factors, or what we call NMFs, that is very important to the integrity of the skin. Filigrein deficiency causes a very significant defect in the skin barrier and can lead to a reduction in natural moisturizing factors of the skin. And this results in dry, flaky skin, which is a common feature of atopic dermatitis. At present, there are no routine laboratory tests to look for filigrein deficiency, although maybe in the future, this will become available. As a first step in the skincare regimen for patients with atopic dermatitis, choose a gentle cleanser that is soap-free and contains ingredients to enhance the skin hydration, such as filigrein breakdown products. The best moisturizer for a patient is one that the patient will apply frequently every day, one that works for the patient, and one that is affordable. Using products containing ingredients to supplement the skin barrier, such as filigrein breakdown products and ceramides, it can help to soothe the itch associated with dry skin. When choosing products, I also want to make sure that the products I recommend are well tolerated. So I look for clinical evidence of products on children's skin and check that they are hypoallergenic. Moisturizers are such an essential part of daily care and form part of the first-line approach to managing atopic-prone skin. Even when the skin is clear, they can help to soothe dry, itchy skin and repair the skin's barrier, preventing entry of irritants and allergens, which can trigger eczema flares. I recommend moisturizers not only to help manage the flare-ups, but also to reduce the incidence of these flare-ups. Some moisturizers have also been proven to decrease the reliance on topical steroids. From a practical perspective, I find that parents don't apply enough moisturizers onto their children's skin. So I ask them to use about 3 teaspoons of moisturizers each time they moisturize their child's skin, 2 to 3 times a day, sometimes even more often. In addition to moisturizers, anti-inflammatory medications, including topical corticosteroids and topical calcineurin inhibitors, are required to reduce the skin inflammation during eczema flares. These need to be started once the early signs of inflammation appear and should be continued until the skin returns to normal, appears smooth, is not red, and not itchy. In a recent study published in the UK called the BEEP or BEEP study, there was no evidence that basic emollients can prevent atopic dermatitis. My group in KK recently conducted a study on babies at high risk of atopic dermatitis, and we included babies with at least 2 immediate family members with atopy. It was a 2-arm randomized pragmatic trial on 200 babies from the first 2 weeks of life. We found that the early use of a specific moisturizing formula containing filigrein technology and ceramides showed a trend towards a lower overall incidence of atopic dermatitis and a lower incidence of moderate or severe disease in infants already at risk of developing atopic dermatitis. Historically, the incidence of atopic dermatitis in children born to one parent with atopy ranges from 25 to 50%, and those born to 2 parents with atopy range from 40 to 80%. In our study, the overall incidence of atopic dermatitis was about 35%.
you.